Good morning, everyone. Welcome to another interesting session of Quest. We will start the program with a word of prayer by our dear Thomas Achal.
Shall we pray? പിതാവിനും പുത്രനും പരിശുദ്ധഹായിക്കും സ്തുതി ആദ്യമേ നന്ദിയേകം തന്നെ ആമേൻ. സർവശക്തനും നിത്യനുമായ ദൈവമേ, സ്വർഗസ്ഥ പിതാവേ, ഈ വ്യാഴാഴ്ച ദിവസത്തിനായി നന്ദി. The last Thursday of November 2024. ഈ വർഷത്തിൽ ഇനിയും 4 വ്യാഴാഴ്ച മാത്രം അവശേഷിക്കുന്നു. ഇത് ഓർക്കുമ്പോൾ കഴിഞ്ഞ വർഷം മുഴുവൻ ഞങ്ങളെ നടത്തിയ വിധങ്ങൾക്കായി നന്ദി അർപ്പിക്കുകയാണ്. പ്രത്യേകിച്ച് വ്യാഴാഴ്ച ദിവസങ്ങളിൽ ഇവിടെ നടന്നതായിട്ടുള്ള എല്ലാ ക്വസ്റ്റിനെയും ഞങ്ങൾ 1 by 1 ഓർക്കുന്നു. അതിന് ലീഡർഷിപ്പ് കൊടുത്തവർ, അത് കേട്ടവർ, അതുമൂലം അനുഗ്രഹം പ്രാപിച്ച എല്ലാത്തിനും നന്ദി. ഇന്നും ഡോക്ടർ അരുണിനെ അവിടുത്തെ കരങ്ങളിലേക്ക് ഏൽപ്പിക്കുന്നു. ഇനി ഞങ്ങൾ കേൾക്കുവാൻ പോകുന്നത് എല്ലാം വീണ്ടും ഞങ്ങളുടെ ഹോസ്പിറ്റലിനും മറ്റുള്ളവർക്കും ദേശത്തിനും അടുത്ത തലമുറയ്ക്കും ഒക്കെ ഒരു അനുഗ്രഹമാക്കി തീർക്കണമെന്ന് പ്രാർത്ഥിക്കുന്നു. ഒരുമിച്ച് ഞങ്ങളെ ഓരോരുത്തരെയും അനുഗ്രഹിച്ചാട്ടെ. പ്രാർത്ഥന കേട്ടതിനായി നന്ദി. ഞങ്ങളുടെ കർത്താവും ഞങ്ങളുടെ രക്ഷിതാവുമായ യേശു ക്രിസ്തുവിൻ്റെ വിലയേറിയ നാമത്തിൽ തന്നെ ആമേൻ. പ്ലീസ് ബി സീറ്റഡ്.
Once again, welcoming to this interesting session of Quest, ABPM, taking hypertension management to the next level. From the classic sphygmomanometer to wearable devices and handheld devices, hypertension measurement has evolved over the years. Today, we will hear from Dr. E.T. Arun Thomas, who is an expert in hypertension management and using very innovative and evidence-based tools for hypertension and its management. We are privileged to have Dr. S.K. Matthew, an accomplished clinician who has evaluated and tried all these instruments and various management modalities over the years. I welcome S.K. Matthew sir for introducing the speaker and the topic. Yes.
Once again, good morning and welcome all for this session. And Dr. E.T. Arun doesn't need any introduction, but for me, he is one of the most dynamic, knowledgeable, soft-spoken and always approachable nephrologist, and I'm very confident with him. And about the topic, the ABPM, in the management of hypertension. And hypertension, as you all know, it is silent killer and it affects the major organs like the brain, the kidneys and the heart. Especially for Asians, it is one of the leading cause of stroke and heart attacks and kidney disease. Now, whenever I train my students and assistants, I always tell them that the first step towards hypertension management is nothing but checking or keep on checking the BP. So there, now we'll be Dr. Arun will be introducing to you about the ABPM. It is a much less used facility which is available in our institution, and it is actually, it's sad to note that so many physicians and doctors don't use this facility, and it is very important in the diagnosis and also the continued management of hypertension. It is established to be one of the tools of good clinical practice in the management of hypertension. Now I invite Dr. E.T. Arun Thomas to deliver his speech on ABPM.
Good morning. Good morning, everyone. Thank you, SK Matthew sir, for the wonderful introduction. And today's topic is on how to use ABPM, that is ambulatory blood pressure monitoring, to optimize hypertension management. So, regarding the BP measurement, I know all the patients coming to our hospital, all the patients who are admitted in our hospitals will have a BP measurement at least one time on that day. But I will say BP measurement is something which you all do in a sloppiest manner. And how many of you can raise our hands and tell that we are doing the BP measurement in the recommended way? Only person I'm very confident about the BP measurement is SK Matthew sir. Sir is very obsessed about BP measurement. He takes multiple BP recording, standing BP, multiple BP recording. So most of the time when I have a patient who is always also seeing SK Matthew sir, I always look at his BP measurement and I find that he sir records BP multiple times in standing BP and all. So with your blessings, let me start the presentation. So how to measure the BP properly? So there are a certain set of guidelines. No caffeine, exercise or smoking for the past 30 minutes. Seated quietly for 5 minutes in chair. Feet on floor, arms supported at heart level. And the cuff bladder should encircle at least 80% of arm circumference. At least take 2 BP measurement and take the average. Inflate 20 to 30 millimeters of mercury above pulse extension. Deflate at a rate of 2 millimeters of mercury per second. Systolic BP is the onset of the first crack of sound, and diastolic BP is the disappearance of the sound. So, just a self-assessment. How many of us do it properly? And even if you do a literature review, and even if you can see there are multiple studies where they observed the healthcare providers measuring the BP, and everywhere they found that 70 to 90% of the doctors or nurses do not follow the guidelines. The implications are very high. Underestimation of the blood pressure by just 5 millimeters of mercury, 2/3 of the hypertensive patients will be missed. And overestimation by 5 millimeters of mercury, more than double number of patients will be wrongly diagnosed to have hypertension. So the first step in the blood pressure management is always make sure that the patient is actually hypertensive and do the blood pressure measurement properly. And even if you do we follow with the guidelines and do the strictly follow the guidelines and monitor the blood pressure, still there are fallacies because the patient is coming to the hospital. The hospital BP is called as an office BP. Always, the hospital is not a comfortable place. Obviously, blood pressures can rise, seeing the doctors, nurses, and other sick patients. So it is called a white coat hypertension or an isolated clinic hypertension, which is seen in 10 to 20% of the patients. So actually they are not hypertensive. The high BP, which is seen when they reach the hospital, is just because of fear and apprehension inside their mind. So they are also not hypertensive. If we just use the clinic BP or office BP to diagnose hypertension and treat the hypertension, we are going to treat a patient who is not hypertensive. And at home, when they're using the hypertensive, they may get hypertensive episodes, they may fall down, and a lot of issues can happen. So how can we pick up this white coat hypertension? There are 2 ways. One is a home BP measurement or an ambulatory BP measurement. And another issue with the office BP or the clinic BP is there is something called a masked hypertension. These type of patients do have a high BP variability. Their blood pressure will not be always in the same line. And actually they are hypertensive. But unfortunately, at the time when they come to the hospital, the blood pressure is on the lower side. So we will miss the diagnosis. And sometimes this patient can have endocrine damage related to the hypertension, but the hospital BP will be normal. So we are going to miss. So this is also 10 to 20% patients. So if we just rely the hospital BP or the office BP to diagnose and treat the patient, first of all, most of the time we are not measuring the BP properly in the hospital. And even if you measure the BP properly, 10 to 20% will have a white coat hypertension and 10 to 20% will have masked hypertension. So wrongly we label many patients to have hypertension and wrongly we will label many patients to have not to have hypertension. So we have to overcome all the issues. And one of the best tools is actually an ABPM. I'll give a scenario for all of you to work out. We have a 46-year-old male no addictions, no comorbidities. Patient came to the hospital, and the first hospital visit of his BP is 150/90 millimeters of mercury. Okay, I told him, so BP is in the borderline range. You could be hypertensive. I'm not going to diagnose you to have a hypertension. So this 46-year-old male, I asked him to come to the clinic next week. Again he came. The blood pressure is 146/90 millimeters of mercury. Oh, it's still a bit high. And third time he came, again it is in the same range. So what should be the next best action plan? Lifestyle management plus single antihypertensive, home BP monitoring, or ABPM. Option A, B, C, and D. How many of you go for option A? So, so you all thinking that this patient is having hypertension, and you go for lifestyle management. And how many of you are going for the option B, lifestyle management with single antihypertensive? I don't think no one wishes to start this person on antihypertensive. How many of you ask for home BP monitoring? Yeah, majority is going for home BP monitoring. And ABPM? So majority is for home BP monitoring, and almost equal number raised hands for ABPM. So let's see. So what I'm going to do, I'm going to put all the three of his BP in the waste basket. This borderline BP, when we measure from the hospital, it is not at all a reliable thing to diagnose or to make any decision. If the BP is very high, like 180 or 190 millimeters of mercury systolic, that means that patient is obviously having hypertension. We can diagnose him to have hypertensive. But this border zones, it could be actually hypertensive, or it could be a wrong BP measurement, or it could be a white coat hypertension. So how can we make a decision with this borderline BPs? It is not possible. So first of all, what I should do is I had to put all these three BP in the waste basket. And we have to make sure that the patient is actually hypertensive before proceeding with the treatment. So there are two ways. We can have a home BP monitoring or an ABPM. ABPM means this machine, BP machine is connected for the 24 hours, and the daytime usually the BP measures in 15 to 30 minutes and nighttime 30 to 1 hours. So we get a 24 hours BP recording, or they can buy a good quality digital BP machine for checking BP at home. And I commonly use Omron because it is an imported brand and validated brand. But the problem with this machine is, so they don't give much margin for the retailers. So most of the surgical shops and retail shops do not keep this good validated machines. So mostly they have to buy it from the online stores like Amazon or Flipkart. So if you ask them to go to some surgical shop and buy some BP monitor, most of the time they get some low quality machines that is being imported from China. So specifically we have to tell them the machine, a good quality. I always suggest Omron, you can have your own brands. And I ask them to buy it from Amazon or Flipkart. It costs only less than 2,000 rupees. So they can have a multiple BP recordings at home using a home BP monitor. Or you can have a ABPM. ABPM means it can be done, they have to come to the hospital, we'll apply the ABPM, they go back to the home, and they will have a 24-hour BP monitoring. So which is easy? We charge 3,500 rupees for ABPM. And to buy a home BP monitor, Omron, it costs only 2,000 rupees. Which is best? How many of you go for home BP monitoring and how many of you go for ABPM? So most practical thing is home BP monitoring, obviously. So we can have the machine multiple recordings, but ABPM has got its own place. Still, it has got its own place. So if the patient is motivated enough, I always feel ABPM is a gold standard. We'll see. So I did a 24-hour blood pressure monitoring for this patient. So 24-hour mean BP is 126/82 millimeters of mercury. So what is the diagnosis? The 3 office BP, that is a hospital BP, is high. But 24 hours mean BP is 126/82 millimeters of mercury. So it is a white coat hypertension. Should we need to treat him? No. Yes. Yeah. So white coat hypertension means we always have to follow up these patients. They may develop hypertension later, and this white coat hypertension is an independent risk factor for cardiovascular events in long run. But we don't have to treat. But if you treat, the BP can go down. So we diagnose white coat hypertension based on 24-hour ABPM. But this can also be diagnosed with the help of home BP monitoring. They can have a multiple home BP monitoring. Again, we can diagnose white coat hypertension. Then why should we look at the ABPM? So I'll come to it. So this white coat hypertension is associated with an increased risk of cardiovascular events and all-cause mortality, and later they may go to hypertension. And it is just a 24-hour average BP is, by looking, it is not over in the ABPM. So we have to look at the segregated, we have to split the BP into daytime BP and nighttime BP. Look at the average daytime BP and look at the average nighttime BP. So daytime mean is 122/80 millimeters of mercury. Nighttime mean is 130/85 millimeters of mercury. So what did you understand? Which BP is higher? It is nighttime BP which is higher. So 24 hours is normal. Daytime is normal. Nighttime is also not very high, but it is higher than the daytime BP. Normally, physiologically, during sleep, blood pressure falls by 10% during sleep. That is a normal physiological. And if this dipping, 10% reduction in the BP during sleep is not present, then that patient is said to be a non-dipper. So that dip in the BP is physiological. We want that dip. If that dip is not present, it is an independent risk factor for cardiovascular events and mortality. So normally during the sleep, BP gradually decreases, and the minimum BP is obtained at around 3 a.m. and after that BP again starts to rise, and maximum BP at 10 a.m. time. So why the BP is going down during sleep? This is because of the decreased sympathetic activity during sleep, during NREM sleep, and also cortisol secretion also follows the same pattern. Cortisol actually sensitizes the blood vessel for norepinephrine, and it increases the BP. Because the cortisol levels also goes down during sleep, and trough level is around 3 a.m. So BP also goes parallel to that level. So we want a nocturnal BP dipping, which is physiological. But look at this patient. Actually, BP should be 10% less, but here the BP is actually higher. The nocturnal BP is higher than the daytime BP. So it's a non-dipper, and this patient is having nocturnal hypertension. This non-dipping and nocturnal hypertension is an independent risk for cardiovascular event, irrespective of the mean 24 hours blood pressure. So that is something which we can pick up if we do an ABPM. We can have an idea of the nocturnal BP, nocturnal dipping, nocturnal hypertension, etc. So doing the home BP, we were not going to capture this nocturnal thing. So that is one catch. So he's at risk. He's at risk for cardiovascular events. And this Osama is a place in Japan where they do a lot of research in ABPM. They have a cohort with ABPM and long-term follow-up. And what they found with the long-term follow-up study of 9.2 years, each 5% decrease in the decline in the nocturnal systolic bar diastolic blood pressure was associated with 20% greater risk of cardiovascular mortality, irrespective of the mean BP. So mean BP, it is normal, but if you do not have the dip, he is at risk. So this patient is at risk. This patient's nocturnal BP is high. So what should we do for this patient? So that is a question. Mean BP is normal, daytime BP is normal, nighttime BP is not very high, but it is high. So normally nighttime BP should be less than 10% of the daytime BP, but this is very high. So this patient is having nocturnal hypertension. So what should we do for this patient? Can someone contribute? Yeah, so Mohan sir is telling that we have to check the obesity, obviously. Target organ involvement, yes. But so I took a detailed history, and what I found that significant snoring. with daytime sleepiness. So OSA is one of the cause for nocturnal hypertension, isolated nocturnal hypertension. So this patient had a obstructive sleep apnea, and I ordered for a level 3 home sleep study. Level 3 home sleep study, which is also available here. We have the respiratory therapist who is going to the patients at home and do this sleep study. And the apnea hypoxia index was 28. So 28 times per hour, the patient is actually apneic or hypopneic. And that is one of the main reason for the nocturnal hypertension. And we have to treat the OSA using a home CPAP and other measures, weight reduction, lifestyle measures, etc. And suppose if you do not get an OSA, sometimes it could be an isolated nocturnal hypertension. We may not get a cause. In that case, we can advocate something called a chronotherapy. What is chronotherapy? Chronotherapy means coordinating the medical treatment with a patient's circadian rhythm. Like we are going to artificially create the blood pressure dip during the night with the help of antihypertensives that are short-acting antihypertensives. We don't want a long-acting antihypertensives. We don't want the action of the antihypertensive lasting more than 12 hours. We want to artificially create a dip. For that, the best thing is an AC inhibitors. So ramipril was studied in HOPE study. This administered at night decreased the CV risk by controlling the nighttime BP, and it was associated with 22% relative risk reduction in cardiovascular death, myocardial infarctions, and stroke, despite of the modest reduction in the BP, 3/2 millimeters of mercury. So they use the ramipril. It is not to lower the overall BP. It is specifically to address the nocturnal BP. And other agents, we can use a nifedipine retard, which has got a peak BP lowering effect in 2 to 4 hours. Clonidine also, small dose of clonidine, peak BP lowering effect in 2 to 4 hours. Labetalol also, which is short acting, 2 to 4 hours. So we can advocate a chronotherapy to artificially create the dip if the patient is having a nocturnal hypertension or a nocturnal non-dipping. And one thing I need to emphasize is here, many of the time we start patients on an antihypertensive, usually start with a monotherapy. And the best time to place the single drug is just before sleep at night. This is because it can artificially recreate, even if it is a long-acting drug, maximum peak action will be at around 6 to 12 hours, 6 hours time. So it can artificially recreate the nocturnal dipping. So it is night time we want the best BP control. But most often, we always start the antihypertensive in the daytime, and we get happy by seeing the daytime BP is controlled, but we do not have any clue how the nighttime BP is like. But it is night BP which is very more important than the day BP. So single antihypertensives, there are a lot of studies which tell that the nighttime dosing is actually better for reduction in the cardiovascular events. But with the newer antihypertensives with a long duration of action, for example, amlodipine, which is acting for 36 hours, anytime you can place it. But if the antihypertensive you are using do not have a 24 hours duration of action, always place it at night, because we want the best BP reduction at the night time. And also taking a single pill just before sleep, the compliance will be good. The morning time, everyone will be very busy. If we're running to the office, hospital, etc., they may miss the dose. Nocturnal dosing just before sleep, the compliance will also be improved. And this is one study. Among patients with diabetes treated with more than one antihypertensive at bedtime, compared with all medications upon waking, with a mean follow-up of 5.4 years, what they found that they resulted in improved ambulatory blood pressure control and significantly reduced cardiovascular mortality if the timing of the maximum number of antihypertensives is at night time. And certain drugs do not have 24 hours action. For example, atenolol and all AC inhibitors, they don't have 24 hours action. And regarding ARB, losartan. So you should not place this medicine at daytime, because we are going to reduce the daytime BP, but nighttime BP is not going to be affected. So if you're using these drugs, place it at nighttime or give in a BID dosing. So either you should use it in a BID dosing or place these drugs at nighttime, because the studies found that placing it in the morning, it increases the cardiovascular risk. And regarding the BP dipping, there is a small subset of population who is having an extreme BP dipping more than 20% during sleep. Actually, this pattern is not benign, usually mainly seen in very elderly. This extreme dipping is associated with cognitive impairment because of the hypoperfusion to the brain during the sleep. And for this extremely dipping patient, if we give multiple antihypertensives during the sleep, it can result in progression in the cognitive impairment. So that is another thing. And reading an ABPM is not just over by looking at the 24-hour BP, daytime BP, and nighttime BP. Another most important parameter where all of you should look is into the 24-hour blood pressure variability. So our BP is not constant. Seconds to second variation, minute to minute variation, hour to hour, day to day. Every time our BP is varying. But that is physiological. But too much variation is not good. Too much BP variation, blood pressure variation, is an independent risk for target organ damage. All the target organ, heart, brain, kidneys, target organ damage, irrespective of the 24 hours BP. 24 hours BP mean is normal, but if the BP variability is high, it is a risk. So we'll get an idea about the BP variability from the ABPM. So multiple studies invariably proved high BP variability is not good. And how to check the BP variability? So variability of a multiple measurements usually is given by the standard deviation. But the standard deviation is for that set of BP recordings. But if you want to generalize, we have to take the coefficient of variance. So that is, we have got a standard deviation and we have the mean BP also. So standard deviation divided by mean BP into 100, that is a percentage coefficient of variation. If CV is more than 10%, that means that patient is having high blood pressure variability. So we have to reduce the blood pressure variability. The best way to reduce the blood pressure variability is to use a calcium channel blockers. Of the multiple antihypertensives, calcium channel blocker is the best one which can reduce the blood pressure variability. Certain antihypertensives may in fact increase the blood pressure variability like a beta blockers and short-acting medications. So CCBs are usually long-acting and reduces the blood pressure variability. So if the blood pressure is not very high, even the borderline hypertension, if you find that the blood pressure variability is very high, I may still start on a small dose of a calcium channel blocker. So now the question is, comparing office BP with 24-hour ABPM in predicting cardiovascular morbidity and mortality. So regarding cardiovascular events and mortality, so you can just see the graph. Ambulatory BP predicts the cardiovascular events much better than office BP. This is because it gives us an idea of the nocturnal BP, gives us an idea about this blood pressure variability. And regarding this stroke risk also, you can see this office BP is not a strong predictor of this stroke events. And home BP is a predictor, but office BP is not a predictor. And of the ABPM, it is a nighttime BP which is a predictor for the stroke. So if you want to reduce the stroke risk, if the patient is at high stroke risk or already had a CVA, then we can use an ABPM to optimize it. And nighttime is the time where maximum cardiovascular events do happen. And regarding the ABPM for progression of kidney disease, so elevated ABPM correlate more strongly with the progression of the kidney disease to end-stage renal disease than clinical BP. And nighttime blood pressure was a more stronger predictor to death and ESRD in patients with CKD. And regarding the cutoff values for ABPM, cutoff values is different from the office BP. So normal, another thing I need to tell here is, what is normal BP? What is the cutoff for normal BP? What is the cutoff for hypertension? So I will tell, there is nothing called a normal blood pressure. This classifications and cutoff and everything is made for enrolling patients for studies and for population-based studies. So if one blood pressure is normal for one individual, that may be abnormal for another individual. What ultimately matters is whether the organs are adequately perfused and whether it is actually a hypertension for that individual. So for example, the blood pressure depends on age As age advances, BP normally physiologically increases. Sex, blood pressure is actually more for females, more for males, less for females. Ethnicity, genetics, and many unknown factors. Just using a single cutoff for defining the blood pressure, it is just like stitching one size coat and asking all these 3 kids to fit inside the cot. So one size does not fit all. Now we are practicing in an era of personalized or precision-based medicine. So we have to go more precise for your individual patients. So just telling that 140/90 millimeters of mercury is the cutoff for treatment initiation, that may be true for some set of patients, it may not be true for some. Some patients will be actually having all the end organ damages related to the hypertension, even if their blood pressure is 130/80 millimeters of mercury. It actually depends on their baseline BP. For example, this is Yanomami tribes. Yanomami tribes are seen in the Brazil and Venezuela in the Amazon rainforest. These tribes do not have access to outside world. These tribes do not have access to table salt, our salt. For generations and generations, they are not using salt. Even the salt came into our routine use nearly 5000 BC back. And even 200 years back, the salt was considered to be something very precious. Now salt is very cheap. Everyone is using a lot of salt. Actually, it is the sodium that is the driving force for the epidemic of hypertension in our community. Sodium increases the blood pressure, potassium reduces the blood pressure. Primitive humans used a lot of fruits and berries which is very rich in potassium and no salt, table salt. So their average blood pressure is very, very low. Similarly, these tribes which do not have an access to outside world, one of the postulation, their average blood pressure is 96/60 millimeters of mercury. If someone from this tribe come to our ER, they may be admitted and started on a noradrenaline, thinking that this patient is having severe hypotension. But this is the normal blood pressure for these tribes. So we cannot generalize one blood pressure cutoff to define hypertension. We have to go personalized. So using an ABPM, we can go personalized, because if you get a BP of 130/85 millimeters of mercury, so that BP can be benign or malignant. So if it is an abnormal, we can get clues from the ABPM like high blood pressure variability, nocturnal non-dipping, nocturnal hypertension, etc. So we can go more personalized for, especially when the BP is in the borderline zone, if we use an ABPM. And regarding the females, the blood pressure is generally low, males it is high. And also age advances, the BP increases. So we should not just stick on with a single BP cutoff for all patients. So these cutoffs are mainly meant for enrolling patients for clinical studies and epidemiological purposes, not for the clinical purposes. So for example, this 42-year-old male with office and home BP always between 130 to 140 millimeters of mercury and diastolic 80 to 90 millimeters of mercury. Is it safe or a risky BP? Should we treat? So I will tell, we cannot make any conclusions from this office BP or home BP. If you want to make a conclusion, just then apply an ABPM, see how the BP variability is, whether this patient is having a nocturnal hypertension. If this patient is having nocturnal hypertension or non-dipping, all the BP in the borderline zone, border zones, we should consider to be at risk. And regarding the ABPM, the cutoff BP for ABPM, normally the BP, 24-hour BP should be below 115/75. And anything above 125/75 mean BP, we should consider it as an abnormal. And 130/80 is the cutoff, and 145/90 in home BP is very high, 24 hours. And regarding the nighttime normally it should be below 110/65 millimeters of mercury in ABPM. So because of the normal physiological decrease in the blood pressure. ABPM also gives us some additional clues. Suppose a patient is having a recurrent episode, syncope or pre-syncope. And if you suspect it because of the low BP or postural hypotension, you can apply an ABPM and you can interpret it. You can just see the fluctuating BPs and hypotensions recorded in the ABPM. And some patients do have an episodic hypertension. If you're suspecting pheochromocytoma or an episodic hypertension, again you can apply an ABPM and you can just see episodic hypertension in the ABPM. And also another important parameter ABPM gives is it also measures the heart rate. If the heart rate is very high in the ABPM, that patients we can use an beta blockers. And regarding the technical aspects to the winding up, so we have a cuff and a electronic monitoring device. And the cuff and the device is connected with the wire. The cuff should be wrapped around the arm, just like the usually how we do for the normal blood pressure monitoring. And the device should be connected to the body with the help of a belt. The problem is the cuff size should be correct. So there are some issues. There are multiple BP recording. There are certain patients develops a petechiae or bruising under the inflating cuff, but it is very rare. And some patients do have a sleep disturbance, something tied to their arms. So that can also falsely elevate the BP, but studies have found that it will not affect significantly the nocturnal BP recordings. And bath or shower is very important. So if you're planning to apply an ABPM for a patient in the morning and continue it to the till day morning, always ask the patient to take a bath or shower before applying the ABPM. Because after tying the device, that patient cannot go for a bath. Another thing is that patient should be wearing a comfortable dress. So if you're asking the patient to come to the hospital, I'm going to apply an ABPM, that patient, a female patient, is going to come to the hospital in a sari, and I'm going to apply the ABPM. Then that patient is going to be stuck in the sari for next 24 hours. So they should come here, take a bath before starting the ABPM, and the dress should be very casual, loose, comfortable dress that should be weird 24 hours. So many of the times the patient come to our OPD for ABPM, and sometimes we may have to deny the ABPM for that person because they are coming, they want to take a bath in the evening. So they may are coming with sari or very tight fitting dress, or some patient, even one patient came with a suit like thing to the hospital. So that is very important. And we have to ask the patient to keep a log. We want to know when the patient is sleeping and when the patient is awake time and the timing of the medicines, what all medicines, then only we can interpret the ABPM. And any symptoms the patient had, like a pre-syncope or any dizziness, anything, they have to document it. And it is mandatory that we should not do a usual BP measurement during the time of ABPM, because if a patient admit the patient to the in the ward in the room, and if you're doing an ABPM, if some nursing staff go with a BP measurement and do a BP measurement, that time they can develop a white coat hypertension. That can affect the overall 24-hour blood pressure measurement. So no usual blood pressure measurement, but they have to keep a log. And the readings we can set it in the computer every 15 to 30 minutes during daytime and 30 to 60 minutes at night. Usually we keep 30 minutes during daytime and 60 minutes during nighttime. And last scenario, we have a 56-year-old male, hypertensive for last 15 years, not diabetic. Office BP is very high, 186/94 millimeters of mercury. The patient is already on prazosin 5 milligram 2 times, amlodipine 10 milligram morning, nebuvolol 5 milligram 2 times. How to proceed? So 3 antihypertensives in optimal dose. BP is very high. So it can be a resistant hypertension. So if the BP, since the BP is very high, we should not directly ask this. The resistant hypertension can be actually resistant, or it can be a pseudo-resistant. So something like white coat hypertension is not a hypertensive patient developing developing high BP recording at hospital. Similarly, hypertensive patients, when they have a BP measurement at hospital, that can again increase the BP. That is called white coat effect. Already hypertensive, already on medicines, but hospital BP is higher than the usual BP. That is white coat effect. But this is very too high to define white coat effect. So what we have to do when the blood pressure is very high, don't subject this patient directly to the ABPM. Optimize the blood pressure with adjusting the antihypertensives. I started a telmisartan chlorthalidone combination and a spironolactone, suspecting resistant hypertension, and the repeat of his BP is 150/90 millimeters of mercury. It came down, but still it is high. And already now the patient is on 5 antihypertensives, of his BP is high, but it is not that high as 186/94. And that is the ideal point where can start on a ABPM. Because this could be because of the white coat effect, or it could be because of the BP variability. At that time when the patient is in the hospital, the BP is high. But evening time it may be low. During sleep it may be low. So doing an ABPM, we get a 24 hours BP recorded, and we can streamline the antihypertensives. We can correctly place at the correct timing for these antihypertensives. So if the BP is very high, don't apply ABPM. Just reduce the BP to a reasonable level and further fine-tune the BP with the help of an ABPM. And adjust the medicines again, and you have to have a redo ABPM to see the response. And for conclusion, 24-hour ABPM is the gold standard because it gives a more accurate diagnosis by picking up white coat hypertension, mask hypertension, and additional crucial information, that is nighttime BP, nocturnal dipping, and BP variability. So the question for the day is, ABPM has several advantages. Yes, doing ABPM is easy. No, not at all easy. So it is cost. Cost is not very high, 3,500 rupees. Many patients can afford. But coming to the hospital, or some technicians going to their home, applying ABPM, having a machine, they cannot go for work for that day. It is very awkward for someone to go to the work with a machine connected and all. So one day is lost. So should we adapt ABPM in our routine day-to-day practice? Yeah. So ABPM. So obviously office BP is very, very less reliable. So one thing is very, very obvious, very definite. The era of office BP is over. We have to emphasize on having a home BP measurement. Ask the patient to buy a good electronic BP device, have a multiple BP recordings at home, and also we can do a hospital BP recording. Ask the patients to take the BP monitor to the hospital and we can validate it. So that is very obvious. And regarding the ABPM, additional cost and efforts from ambulatory blood pressure monitoring are counterbalanced by the cost saving due to complication prevention from better and targeted treatment. So that should be one conclusion. So it is difficult, it is cumbersome, but everything is counterbalanced by the cost saving, because in long run they develop a cardiovascular events, the time, effort, money, everything we spend for treating the cardiovascular complications is much higher than the efforts we take for a ABPM measurement. And there is a subset of population where the ABPM is very useful. So I will say it is a borderline BPs. If the BP is borderline, obviously like young less than 50 years, BP is like around 130 or 140, 145. This borderline BPs should always be asked to do a ABPM to fine-tune the diagnosis and management. And for patients on multiple antihypertensives, it is good to have an ABPM to know how the BP is behaving 24 hours, where there is any significant fall in the BP at any particular time, or is the BP still controlled, fine-tuned the antihypertensives. So patients with multiple antihypertensives and borderline BPs are two subsets where ABPM is very beneficial. And for all others, additional cost can be counterbalanced, but we cannot force anyone. And also it is cumbersome for us also. We have to motivate the patient, initiate ABPM and all. But ABPM is obviously a very beneficial thing. And now all the guidelines on hypertension, all the societies endorse ABPM as a gold standard tool. So that's all. Thank you very much.
Thank you, Dr. Arun, for that lucid and very practical presentation on hypertension, BP measurement, and of course the importance of ABPM. What I would like to comment is that if you want to treat BP, then one should measure the BP by oneself only. We should not rely on anybody else's BP. And second thing is that you insisted on the importance of ABPM in nocturnal hypertension, and also as the best way to assess out-of-office measurement. But there are many people, many patients coming with the early morning surge. What's your comment on that?
So
There is people are going to the office, people are going to drive in the busy traffic. these patients may have early morning surge.
So physiologically, BP is lowest at 3 a.m. and it starts to rise, and the peak BP in the 24 hours is at around 10 a.m. time. So this morning surge, like 8 to 10 a.m. time, this is a physiological surge, and we may have to address it with the help of a morning dose in that patient. So as Sir told, multiple BP measurements and at multiple times can get us an idea about it. But early morning surge, obviously we may have to start a chronotherapy at night. And morning time will be obviously very hectic and busy for everyone.
And many patients also take the BP medications with other drugs like anti-diabetics, and they all combine it. But it's important to time the BP medications according to their activity and also according to the need as delineated by the ABPM. And as Dr. Arun said in the end or as a conclusion, ABPM is one thing which is very less used in our practice here, and we should advocate ABPM for I think on a physician based, and also whoever is treating hypertension, it should be thought of and it should be given for it should be advocated for patients, especially home ABPM rather than hospital based ABPM. Thank you. Any more questions, please?
Anyway, pseudo hypertension is still a problem here. Elderly people is growing up. Yeah. So we have to address that pseudo hypertension also very carefully, because the number of people are getting elderly. Geriatric population is increasing in number.
Can palpation of the blood vessel gives an idea?
Yeah, idea. That is one of the good idea where you can reasonably calculate, because of the increasing the BP drugs, will ultimately can lead to syncopes and fall and fractures, and that is one of the common challenges we face.
If the patient is coming to the OPD for the blood pressure management, it is ideal that we only measure the BP. First with the palpatory method. During the palpation, we get an idea about the vessel wall, and then go for the usual BP measurement. So, but most often, the nursing staff and everyone is measuring the BP. And if the patient is coming per se for the BP treatment, at least for that patient, we should measure the BP in the recommended way.
About the BP instruments, nowadays this sphygmomanometer is not there. What's your opinion about the different BP instruments, like the aneroid, and then we have the oscillometry? Which one is the you think is the best?
Actually, the best is actually the mercury, but unfortunately, because of the environment hazard, that we will not be able to procure the mercury sphygmomanometer anymore. In that case, the aneroid or oscillometry, both are everything is good, but always we have to buy the machines from the validated companies. So most practical issue I find is the patient will go to some surgical shop and buy an BP machine, electronic BP machine, and invariably that machine will be wrong. And usually they are manufactured from the China. They don't have any brand, or they may be imported and rebranded from China. So at least if you're asking the patient, buy it from a validated, reputed brand. And from the hospital setting also, aneroid and oscillometric from a good calibrated brand. And always we have to calibrate the BP machine. These things should be calibrated.
This is the order. Mercury is the best. Next is aneroid. Third is the electronic.
But the advantage of the electronic is they can just press for home BP measurement. Electronic is the best because they don't have to inflate the cuff. So someone is doing a home BP measurement by himself or herself, and if he or she is trying to inflate the cuff and to have this stethoscope, it can also increase the BP. So for home BP, always I advocate electronic, otherwise aneroid. Thank you.
Before we wind up from the Department of Nephrology, I'd just like to announce that we have a hypertensive clinic which we run in our department, we also have the ABPM machine. So any departments, any of the departments, including means any clinician having a doubt that the patient can have white coat hypertension or is it really hypertension, actually should refer patients, or you can make use of our ABPM machine. You can send the patient to us from your own departments, and we can give the machine, and that patient will remain yours itself. We don't have to send it to nephro. Like Dr. Jensi sometimes used to call me and tell, we used to give the machine, we apply it, and then we take the machine back. The patient is yours, the ABPM reading is also yours. So, but we just keep the machine with us. So I would request that feel free to send any patients you have a doubt for ABPM admissions. You can keep the patient under yourself. We'll come and tie the machine for you, and the next day we'll take it and we'll give you the reading as print.
They have to be admitted.
They have to be admitted. You can admit under yourself, under your department.
Actually, it's a disadvantage as the patient is admitted.
The problem
he won't be able to record his own or her own environmental situations.
What we do is we ask these patients to create an environment at home, exactly how much you can recreate it in the hospital. So it's like, go with your regular activities, go out, walk through the corridors, and write down whatever physical activity happens during the day, and let us know so that we can connect it with the readings that comes out. So, but we cannot give the machine and send it because it comes to around
1.5 lakhs.
1.5 lakhs, the cost. So we can't send this machine with the patient. So we have almost, now we have one, we are procuring one more. So please feel free to contact us anytime. We are ready to do it. The problem is, as we go out of this auditorium, we have a tendency to forget it because the work is, we have a lot of patients in the OPD. To deal with all that is not that easy. And we depend many a time for the sisters to record the BP for us. And once you get the blood pressure, you have a doubt, then only you cross-check. It's like this because vitals are already taken when the patient comes to you. So these are the issues. But I think we can take it more seriously, especially for the young people, so they do not develop the complications of hypertension. Thank you.
Thank you.
Thank you, sir.
Thank you, Arun.
Thank you, sir.
Thank you all for coming. See you next week.